this case in which the IOL had opacified and was looking like a mature cataract. And this is the anterior segment photograph. This is the fundus photograph, which shows a dense opaque media which is hardly providing any view of the fundus. Interestingly, this patient has already undergone exchange in the left eye, and this is the outcome in the left eye, which was done about 2 months back. So this is the surgical video, which has been fast forwarded twice the speed, and the incision was placed at the steep axis, and also opposite clear corneal incision was planned to neutralize the pre-existing corneal astigmatism. So removing these IOLs has few options, and one of them is cutting the IOL and removing it. However, these foldable IOLs, especially when they are inside the eye and at body temperature, they are very soft, and as a result they can be folded inside the eye, and this is what I will demonstrate. So what you need is an incision which is slightly larger than 2.8 or whatever size the IOL is to be implanted, and then you get the IOL freed from the capsular adhesions. Because these are hydrophilic IOLs, so usually they have a Rayner design of haptic, which causes entanglement of the capsule, because anterior and posterior capsule both get fused in the portion where the haptic is fenestrated. So it is important, it may be important at times to cut the haptic away so that the bag is not disturbed. And here, as we can see, one of the haptic was free. However, this haptic was entangled in the bag, so it has to be cut open. So we can see the haptic is being cut so that the IOL optic is released, and we leave behind the portion of the haptic which doesn't matter. Once the haptic has been truncated, the IOL is relatively free now and can be pulled out. So this technique is to twist the IOL inside the anterior chamber so that the IOL can be pulled out, and while traveling into the tunnel it automatically gets folded. The incision is to be enlarged slightly, as we can see, and then you place a dialer above it and hold the optic in such a way that one of the haptic is grasped in the forceps grip. So once this grip is properly conceived, then you simply place the dialer above it and twist the IOL so that the optic folds, and the haptic assists in this folding part so that the endothelium is not damaged. In this way, the IOL can be explanted intact for any other further research or review without damaging the optic. A new IOL, which is a hydrophobic acrylic monofocal IOL, was implanted as the PC was absolutely intact, and this IOL will be dialed in place. Now these are a batch of IOL which were in practice in something like 2010 to 2015, manufactured by one of the companies, and these IOL progressively got opaque in all these patients. Probably this was due to a defective batch, and these patients frequently show up now after 5 to 10 years of implantation with a opacity in the optic part, and which causes a gross diminution of vision. These IOLs need explantation and exchange with a fresh new IOL. Here we can see opposite clear corneal incision was planned, so it will be delivered now. So opposite clear corneal incisions are best delivered while the IA cannula is in place, which can provide you a very good guide where to place the incision. Once the incision has been done, the anterior chamber is inflated, and this is the day 1 post-op picture. This is the day 7 post-op picture, and now the fundus is very well visible to us, as we can see here. And so this patient was turned from this kind of IOL opacity to this clear IOL in place with visual gain of 6/6. Thank you.